We looked previously at mechanical ventilation in respect to the iron lung, which was a negative pressure machine. Most mechanical ventilation now is done through a positive pressure ventilation, which means that airway pressure is applied to the patient's airway through an endotracheal tube or a tracheostomy tube. What could cause a patient to require mechanical ventilation? Chronic lung disease, such as interstitial fibrosis or chronic obstructive lung disease, as acute asthmatic attacks, congestive heart failure. Drug overdose will cause a depression of the respiratory centers, and literally the patient will stop breathing. They'll become hypoxic, hypercapnic. Neuromuscular diseases such as ALS, polio, post-polio syndrome, Guillain-Barré, chronic inflammatory demyelinating polyneuropathy, Charcot-Marie-Tooth, and myasthenia gravis, to name a few. Infection and sepsis seems to be a huge reason that people will end up going on to mechanical ventilation. Multi-organ shutdown will be part of that sepsis. Most patients who have cardiac surgeries will require mechanical ventilation in the immediate post-op time. And acute respiratory distress syndrome, or ARDS, is a life-threatening lung condition that prevents oxygen from getting to the lung and into the blood, often caused by aspiration of vomit, inhaling chemicals, lung transplantation, pneumonia, again, septic shock, and trauma. There is an interesting phenomena that occurs with patients on mechanical ventilation. It's called VID, ventilator-induced diaphragm dysfunction. When a patient goes on to mechanical ventilation, the diaphragm starts undergoing change because there's too little stress on the respiratory muscles, and they're literally being rendered inactive. And this is people who are on a mechanical ventilation that is doing all of the breathing for them. It causes a rapid disuse atrophy of the diaphragmatic muscle, and this will occur within 18 to 68 hours of full ventilation. So in this controlled positive pressure ventilation through an endotracheal tube or a tracheostomy will cause complete cessation of diaphragm activity. And is not noticed as much in partial assisted ventilation, where the patient is required to do a certain percentage of the breathing and is not entirely taken over for them by the fully controlled ventilation. And patients who are on this mechanical ventilation in this state, after a period of time, there's a percentage that will have a difficulty weaning off that ventilator, and it's called a failure to wean. And it may occur in up to 25% of ventilated patients. Aggravating issues that can make this response by the diaphragm even worse. Again, sepsis, infection, or systemic inflammation. Malnutrition or poor nutrition, patients who have chronic electrolyte abnormalities, patients with hyperglycemia, patients who have excessive resisted or elastic loads to breathing, prolonged use of corticosteroids, patients who've had exposure to muscle relaxants, and patients who have compromised cardiac function. Patients who end up with VID, or ventilator-induced diaphragm dysfunction, they have found that 50% of the fibers of the diaphragm have a reduced cross-section of both the slow and the fast twitch fibers. And they've also found that mechanical ventilation can cause almost a complete cessation of diaphragmatic electrical activity. Some of the studies that I read, they talked about atrophic injury appearing to result from increasing oxidative stress. And these critically ill patients can lose 1% of their body lean mass per day. So there's a change in the protein synthesis of muscle. And weakness is reported in 25 to 65% of patients that receive mechanical ventilation for over 5 days. And they're now starting to look at this weakness as kind of a global weakness. And 25% of patients who are on a ventilator for 5 days or more have difficulty achieving ventilator liberation. Again, that failure to wean. An interesting phenomena that coincides with long-term mechanical ventilation is called critical illness myopathy. It occurs in acute illness, post-surgical situations, post-trauma, and with burn patients, some burn patients. There's certain risk factors, such as the severity of the illness. Is sepsis occurring? Is there multiple organ failure? Patients who have prolonged immobilization on bed rest? Patients with hyperglycemia? The elderly, it's usually over the age of 60, and mechanical ventilation. It's called intensive care unit acquired weakness. 30% of mechanical ventilation patients of 5 days or more will present with severe muscle wasting and generalized paralysis of all upper extremity, lower extremity, and trunk muscles. And greater than 10 days of mechanical ventilation will affect up to 65% of patients. It's due to microvascular changes, electrical axonal degeneration, metabolic issues, and bioenergetic alterations. Usually it will affect the proximal limb and girdle muscles and the respiratory muscles. And what leaves intact is the sensory, the cognitive function, as well as facial and ocular muscles. Critical illness myopathy pathophysiology. In this situation, the microvascular changes in the endoneurium due to sepsis will often cause a leaking of toxins into the nerve ends. And this edema results in impaired energy delivery, axonal destruction, and will lead to a critical illness polyneuropathy. So muscle myopathy occurs early, and it's a breakdown and a decrease in muscle protein synthesis. And it is often related to inflammation, immobilization, endocrine stress, decreased nutrition, decreased microcirculation, and denervation. And muscles of septic patients show bioenergetic failure through oxidative stress, mitochondrial dysfunction, and ATP depletion. So the outcomes of VID and intensive care acquired weakness are not great. It's an excellent study to read by Daniel Martin in 2013, and he looks at mechanical ventilation, diaphragm weakness, and weaning. He found that there's a very poor 1-year functional outcome and a poor outcome for survival. And the mortality rate of this particular problem is anywhere from 20 to 50%. He also said that 65% of these people who have VID or intensive care acquired weakness 1 year later are still fully dependent in their ADLs.